Well, hi. I'm Lawrence Robbins, Associate Professor of Neurology at Chicago Medical School. I practice a little north of Chicago. And I do mostly headache and psychopharmacology and some neurology and a little bit of general medicine, but I love teaching the med students and residents. If you like this video, we have others. My channel is Lawrence Robbins, and we have about 1,000 videos, other people's videos, the best that I can find in various topics. And under my videos, most of them are in the clinical pearls section. So we'll have others under general topics and then various other topics. So phase 3 studies do usually hold up regarding efficacy, but not adverse effects. I have a separate clinical pearls talk that I have up on why studies miss the side effects. And it's a big problem. The FDA really has to change how side effects, how adverse effects are acquired in studies. I'm much more interested in adverse effects, which is what the doctor or provider and the patient feel is more likely than not from the drug. Not just any random occurrence like nasopharyngeal symptoms or headache, which you see in most studies. Those are adverse events. We should really focus more on adverse effects. And the adverse events really lead people astray. But there's a number of reasons why we can't really trust the PIs when they first come out. For one, the studies don't use a checklist. If you don't have a checklist that you ask people about, you're going to miss the adverse effects in general. So we did this study with the monoclonal antibodies for migraine, the CGRP monoclonals, and we first asked them in the usual way that is asked in studies, how are you doing, and any problems, any side effects, and might ask another question. And then we presented people with a checklist of 18 possible adverse effects that we carefully defined and went over, and we asked, if you had this pre-existing the study, has it really worsened? Do you think it's from the drug? And we decided if it's more likely than not. And interestingly, 2/3 of the patients had at least one more adverse effect when we used a checklist. So we're really missing it. Some adverse effects are notoriously underrepresented, like depression, like sexual side effects, hair loss. So we look for signals. The buzzword is signals, which means in the FDA reports or case studies, etc., do we think that this might be an adverse effect from a drug? And we found 18 of them. So the studies really should use a checklist. Another issue is the adverse effects become disaggregated. All of these, for instance, are synonymous. Fatigue, one person might say they're tired, another has malaise, and there's many examples of this. Each might garner up 2%, and the total might be 6%, but each then falls below the threshold to list it, and that's a big issue. The phase 3 studies, very importantly, are not powered regarding adverse effects. You need more years, and you need more patients. It's a big problem. So how do we discover post-approval, once the drug comes out, the true adverse effect side effect profile? So until they change it, we really need to put multiple lines of evidence together. Post-approval FDA reports. We need case series and other post-approval studies. The high prescriber thoughts, which we can get on chat boards and at meetings and on the phone and email. Our chat boards are very important. We have some headache chat boards with providers where we'll have hundreds of opinions, and I think that's extremely helpful. And we also looked at patient chat boards with, I think they're downgraded and physicians don't really pay them any heed, but when we went over thousands of comments and we came up with highly believable ones, 490, those comments lined up very well with our other lines of evidence. They were pretty accurate. For instance, a patient might say, I'm 58 years old. I never had hair loss before. I went on this monoclonal antibody, the injection. My hair immediately started falling out. And when I stopped it, the hair came back. When I started it again, the hair started falling out again. That's a highly believable comment. And I think that's very valid and very important. Our own personal communication with other providers is very important. And I think that the communication with patient groups is also important. There's a lot of lines of evidence that you look at when we look at this. Of course, the FDA reports are very important, and we have to parse out what's real on those reports and not. But the bottom line is that it's difficult with a lot of drugs to really trust the PI when it comes out, and that's a ginormous problem. Because what happens is patients every day go to their doctor and say, I'm having this side effect, or is this a side effect? The doctor looks in the PI and says, no, it can't be. We've never heard of this. The patient is minimized, their complaints are minimized, they're dismissed, and the doctor, the patient does not like their answer. The doctor's really puzzled and doesn't know, and it leads to the patient continuing the medicine with the side effect. And we've seen that a number of times with these monoclonal antibodies. So now on to boundary issues, which I think are very important. Be very careful treating family and friends and coworkers. I've defended some doctors who are in trouble with the Department of Regulation, and often it's treating family, friends, coworkers without a chart, without charting. If you treat them with controlled substances, it's a real problem. We need a chart. We need charting. We need to treat them just like a regular patient. But most things you have to get into people's lives and ask about their anxiety or depression, their personal lives. Things come up. Do you really want to know that in your family, friends, and coworkers? No. If you're treating something very simple, dermatologic condition or maybe asthma, okay. But for many things, this is where physicians and providers get in trouble. With borderline or antisocial personalities, really be careful of boundaries. They need boundaries. They try to enmesh you into working with them or have them work in your office or a romantic relationship. This is all really bad ideas. And it doesn't lead to anything good. In fact, it leads to people losing their license for a while. So, how to discuss psychological conditions such as bipolar with patients is a tricky issue because of the name of bipolar and the connotation. It's not as bad as manic depressive. So we tell people, okay, you're bipolar, even though they're in the mild end, and we're going to give you this medicine. Oh, it happens to be an antipsychotic, even though you're not psychotic. So it all leads to patients not accepting the diagnosis and not accepting the medicine. So I'm very careful. It's a case-by-case basis. If people are very wary and I don't think they're going to accept it, we'll use Depression Plus, or we'll dance around it and get their trust, and maybe in 3 or 4 visits talk about it. And then some patients, the first visit, want to hear it, and they say, absolutely, I've always thought this, and it's really a tricky thing. I wish in DSM-5 they had changed the nomenclature of the personality disorders, because a lot of the names don't make any sense, like borderline, and that they had changed the bipolar name. It just is too pejorative. But you get a gestalt in your feeling on what they want to hear. Anxiety, we try to medicalize it, and then we can get at the psychological aspects. People, if we don't hit them over the head with it and say it's all in your head or it's all psychiatric, because in the end, psychiatric is physical, and we're talking about the borderline between neurology and psychiatry. With coming functional MRI and more sequences in the next 10 years, we're going to discover a whole lot more about what's going on in the brain with psychiatric conditions, but we know a lot. So I might call it the hyperactive amygdala. Most patients seem to know amygdala these days, and it medicalizes the condition. I'll also bring in evolutionary medicine. I have a different clinical pearls, one of my lectures on evolutionary medicine. I teach this. I think it's very important and very interesting. So I tell people with anxiety, for instance, that a couple million years ago, you were at the watering hole in the savannah and you heard a little rustle. Is it a kitty cat or is it a tiger ready to eat you? So it really pays to run away constantly. And now, with mismatch with the environment, our environment's changed greatly. Anxiety and panic doesn't have as much of a functional role. Anxiety certainly does, and you need to have anxiety. There's syndromes where people don't have anxiety. But in general, panic attacks, there's not a lot of spiders and not a lot of snakes that are going to kill us these days. So bringing in evolution to explain the reason behind anxiety, I think, is helpful. We push exercise all the time on patients, and I'm really not preaching to the 20% of exercisers. It's the 80% that we're trying to motivate. The mantra, you have to get your heart rate up, you have to sweat for an hour. It just didn't help anything, and that was wrong. The New York Times has published some nice articles on 10 minutes of exercise, 10 minutes 3 times a day equal the same as 30 minutes the same time. We're trying to get an average of 20 minutes a day of anything. Walking, treadmill, bike, elliptical. I like the little mini trampolines. The Bellicon is particularly a good high-end one. If you actually, interestingly enough, write a prescription for exercise, that can help. So we harp on exercise almost every visit. And exercise decreases your risk for every neurodegenerative condition. And once people get into these conditions, exercise is crucial. So the placebo, nocebo, placebo by proxy, etc., very interesting. These all have physiologic effects. Placebo effects are very well known. Nocebo is physiologic also. If we present a drug in the nocebo-ish type, well, it might help. There's some side effects. Maybe it'll help. It's less likely to help. Placebo, and these are all very physiological, putting out dopamine, putting out internal opioids. Aware placebo, where people know it's placebo, still is going to work very often. We have different categories of placebo. We'll have active placebo where, say, it's antidepressant, tricyclic. For pain study, there might be an anticholinergic as an active placebo. It will give you the dry mouth, but it doesn't have active effects on depression, etc. Aware placebo is very interesting. You have surgical placebo where you're doing a coronary bypass, but some of the patients don't get it. Within the placebo category, if it's a big pill, people have more of a response. If it's a capsule, they like the response better. Injection, you get more of a placebo effect. If it's a provider that has a preeminent reputation, it's somebody older with a huge CV or something versus somebody just out of residency, the placebo effect is bigger. And so on. If there's no placebo arm in the trial, you're going to get a bigger effect size. People have better expectations. It's people's expectations of the effect in a trial. So a lot of things, there's other factors go into placebo. By proxy, so if a mom brings in her daughter Heather and says, you mentioned topiramate, and mom says, oh, that was the greatest drug in history of the world. you're going to get the placebo by proxy. Also the genetic effect with her daughter, Heather. On the other hand, if you mention a drug and mom says, oh my God, that almost killed me, you're not going to give it to Heather. And these are also physiologic effects. So it's interesting with placebo and nocebo by proxy. They've done some interesting studies, just like with placebo, not quite as many, but you also get the internal opioids and you also get the dopaminergic effects in others. Family history of response to drugs can help you diagnose. So you're talking to a patient about depression, you need to parse out bipolar, and we have a whole separate clinical pearls talk on personality disorders in the bipolar spectrum. But bipolar is 60% of chronic depressives or people with depression frequently in their life. 60% are in the bipolar spectrum. Similarly, under age 18 with major depression, certainly 2 of them, 60%, if you follow them till they're 30, will turn out to be bipolar. So we're always teasing it out. Young depression under age 18, bad reaction to antidepressants or other drugs. The bipolar reaction, up all night, wired. But you can also use a family history of response. My mom took Zoloft. What happened? Well, she was up all night, wired, and felt crazy. That's the bipolar response. And you can use that. It doesn't say that your patient is bipolar, but it gives some indication that there's bipolar brain chemistry running around in the family. With vitamins, it's buyer beware. Be careful promoting or selling them out of your office. Really, the studies are out there on vitamin D. 20 years ago, I started promoting vitamin D. Helps a lot of things, and the studies have helped up. But there's very few studies on multivitamins. ConsumerLab.com and others have assessed quality, and they just don't hold up. They looked at 20 multivitamins, and only 2 really had pretty much exactly what you'd expect. 18 did not, and 8 had arsenic and lead levels. There's a lot of adulterants. If you look for USP certified, which is not easy to get, Nature Made is one. For instance, in a small study, several small studies, men with prostate cancer who are taking a lot of multivitamins for a few years had a higher grade of cancer than men not on the multis. Vitamin C was promoted for the cold ever since Linus Pauling pushed it, but they never proved that it helps colds, it can irritate your stomach and kidneys, and it can do some positive things, but not that much. Vitamin E, though, is an eye-opener. For decades, it was promoted, take vitamin E for everything. And then 10, 12 years ago, there were 2 major studies, vitamin E in at least 400, 600 units a day, increased heart problems, and very importantly, early death. Death is a good endpoint to look at. So everybody threw their vitamin E away. It can help certain things like the eyes and eye health, but I think lutein does the same thing and is safer. Similarly, with herbs, it's buyer beware. Quality control is poor. The majority don't hold up. The average bottle only has about 17% of the active ingredient. Some have adulterants. They can irritate the liver. And the claims really rarely hold up to scrutiny. For instance, echinacea was promoted for the common cold for 40 years. And finally, they put people in a Holiday Inn, gave them a cold virus into their nose. They paid them. And for 7 days, they recorded every sniff and every cough. And after 7 days, the people on echinacea didn't have any less coughs or sniffs or anything than the people who were given placebo. Pitalulex, on the other hand, is an adulterated herb. They take the molecule off that we worry about, and it's out of Germany. It was the #1 medicine for headache in Germany for a while. And I think 50 years it's relatively safe, but it's highly controlled. The parent compound of Pitalulex, butterbur, I don't really think is all that safe. So when you take a history, you really have to focus people. It's not a psychiatric interview. Open-ended is fine, and you need people to be listened to, but some people, it's just the way their brains go. They'll ramble, and you can't let them because nothing gets done. You'll end up with half an hour and you'll know one or two tidbits. If they bring in a list, try to get to that first. You'll get to know your patients. Don't chit-chat and it's 15 minutes and then they pull out a list. You think that it's all over and they're fine. Oh, doctor, I have a lot of things to talk to you about. So if you can get to that first, it actually helps if you take the list and can go over the numbers yourself because it's faster. But you need to take a history in a timely manner. On the other hand, the longer we listen to people, the better a provider, physician, PA, nurse practitioner we are. If the patient says something and you they forgot to say it on the way out, you have to really sit down and reassess. You have to sometimes bring them back in and back up the bus and throw away your whole plan. They might walk out and say, oh, by the way, I was just diagnosed with asthma, or I've been severely depressed, something like that. That night, you might think of something. You know, when a patient comes in and you have a busy day, it's 4 o'clock, 6 o'clock, and the patient's complicated and you get interrupted, there's a lot of things to think about with these patients. The various buckets outside of medicine, which medicines, what to think about for the future. We always want to put for the future our possibilities and number them. So later on that night, you sit up at midnight and you think, oh, with Mrs. Smith, I really should have thought of this and this and this. You've got to pull the chart the next day and write it in or type it in. Very frequently, we can't think of everything, and we're trying to think at deeper levels. And the better providers think at levels 3, 4, 5, much deeper, and we can't always do that when we're tired and stressed. So now sometimes patients they have their own agenda, they want you to agree with them, but that's not our job. If we really think it's important, we need to tell them, look, you are here, I'm trying to help you, I'm your advocate, you are feeling this way and you think this, but I disagree and I think it's important and I'll tell you why. But a lot of times we don't hit people over the head with it. If it's not important, we just go with the flow. So some patients just naturally are ramblers. There's severe ones and then there's mild ones. Usually they're not too bad, but if you ask, did you have a headache yesterday? And the patient says, you know, it's interesting that you asked, doctor. Well, we woke up and we were going to McDonald's and no, I think it was Applebee's. And so then my husband started telling me about his cousin who had a roommate in college in 1970, and his roommate's cousin was graduating, and pretty soon you are so lost in many branches of that tree, you need to refocus people. Some people will talk over you, and that's difficult. A lot of doctors just give up naturally when the patient won't let you in. Where can I get into this conversation? But if it's really important, sometimes you have to say, just time out, wait, stop your brain spinning, quiet. You've talked for quite a while. I have the idea. Let me just tell you. Now, if the patient then talks over you, most providers do give up, unfortunately. You know, listening has been looked at with various studies in the ER with certain complaints like dizziness. The patient will talk 7, 10, 15 seconds before they're interrupted. And for instance, dizziness, it's really crucial. The only way to tell is to take an accurate history. What do they mean by dizziness? So it is a tough problem with some patients getting back into the conversation. But the more we spend time with them, the more squeaks out and we're much better. If you know your countertransference, I'm loosely using that term, but if you know what touches your buttons, angry man, an angry woman, angry older person, it helps you greatly in managing your feelings. If a patient has is somatic, many somatic complaints. A lot of physicians and providers don't want to deal with that. They don't feel comfortable. But if you put up a little bit of an emotional barrier, you don't get enmeshed. I think televisits help greatly because there's not that tension in the room and the anxiety, and the patient doesn't have papers spread all over the table. You can control it. I think it really helps. But if you put up a barrier, you can get to all of the complaints. Dealing with personality disorder patients, so I have quite a bit on our Clinical Pearls personality disorder talk. Most have a mixture of PD characteristics, but it's about 5% of the population that has a moderate to severe personality disorder of the following type: borderline, antisocial, narcissistic. And these 5% really cause 95% of all the problems with clinics, providers, and the world, and corporations, and countries. So if a patient has one of these bad personality disorders, keep boundaries. That's crucial. Don't put up with any abuse. And our instinct, and I've spoken with schools on this, I've spoken with HR departments at corporations, the instinct is to kill them with kindness. Medical clinics go astray doing this all the time, and they get their hooks into you, and it just gets worse and it accelerates. It's pay me now or pay me later. You either confront the situation or you push the can down, kick the can down the road, and it blows up later. Mild personality disorder pathology is different. Most patients can contain it. It's more severe, and you really can't put up with abuse. But be careful, document, don't be enmeshed. A lot of providers have gone into business with these people. They've gotten into romantic relationships. And in the history of bad ideas, this ranks up there. It never really ends well. So recognizing personality disorder pathology is not so easy. Bipolar, anxiety, depression, these are relatively easy. Personality disorder pathology, sometimes it takes days, weeks, months, and years. We've had people 15 years later, we realized what we were dealing with. And be very careful with addictive substances. Benzos and opioids have their role, but we need to use minimal doses and in last resorts, and particularly with personality disorders. Speaking of controlled substances, we try to do a PMP on every patient, every visit, the monitoring program. And we can do surrounding states. I wish they had a national program, but this has greatly decreased abuse and overuse. Don't ignore red flags. They have to be addressed. The problem is that the physicians often, it's easier not to confront or to have to deal with it. You're busy, but that leads to major problems. Be careful with new patients that you don't know. If you give a controlled substance, give a very limited amount. And as I mentioned, benzos and opioids are fine, but they should be a last resort and used in low doses. Try not to use them with personality disorders and not in the young people. We don't want to be the first to hypersensitize somebody's brain with opioids. Really try to avoid treating staff and family members with these. You know, it's funny how they classify them. There's 2, 3, and 4. 2 are your stronger oxycodone, hydrocodone, and 3 is still codeine and tramadol are still 3 even though they're opioids. Tramadol increases some serotonin and norepinephrine also. It's mild. It's probably the most commonly used opioid. And there was a long fight to get it controlled. Initially it came out as non-controlled. And benzodiazepines are 3. With Schedule 2, you can't write refills. You can only usually do 1 month. You can e-scribe 1 month, or you can write out 2 or 3 months at a time for the patient, but the second, you have to date them the day that you wrote them. You have to have the address on there. And you have to write on the second or third one, fill after a certain date. So fill after 1 month from now, for instance. So heed red flags. If you write 30, you have to then write 30 in script afterwards. So for opioids, you also lately have to write the code very often, whatever you're treating them for. Often it's pain, G89.29. And you have to be able to say no and set limits. Patients push. They might say, this is a great drug, but I need more, and you have to say no. Now, where these can work out long term on a daily basis is when people don't get tolerant or tachyphylaxis to the drug. But how often does that happen? It does happen sometimes, maybe 30, 35%. I don't know the exact percentage, but it's significantly minority where they don't get tolerant. And I've had patients on daily opioids, 1 or 2 pills for 25 years. They don't need more. But most patients, unfortunately, will need more. So each visit, we document the condition or pain, functioning, moods, and overuse abuse. Now, functioning is a lot different than pain level. You can increase people's pain level, but functioning is different, and it brings about first 15 years of life, modeling, genetics, catastrophizing. Catastrophizing is actually the number one predictor of disability, not the pain level. So I mentioned we'll use these as a last resort. You know, how do they control these? They'll use a likability index. If people like them too much, they'll control them. It might be a class effect. It might be a mechanism, like Vyburzi is for irritable bowel syndrome with diarrhea, and it works on mu-opioid receptors in the GI tract, so it's a class effect. So things that are controlled aren't always necessarily very addicting. Some of them are hardly at all. We always address isolation and loneliness. It's a big issue. We have an isolating society. The pandemic drove isolation, and a lot of people with introversion didn't care, and many people are 60% introverted, and then in the right setting, they're extroverted, but many people are introverts. But it's the pure extroverts who really suffered during the pandemic. The health clubs are somewhat social. We encourage them. In UK, they have a loneliness minister. That's a good idea. And people, even within a marriage or a relationship, can feel isolated or lonely, so we address it. We do push therapy, physical therapy, psychotherapy, trainers. At least it brings other people in. Weight gain is often a major issue. About 8% of our patients with weight gain can't gain weight. So that's an issue that is very difficult. If people are 88 pounds and they just can't keep a pound on and they fall to 86, it's a big difference. And a lot of drugs cause more weight gain than they list. So we try to minimize doses of weight-gaining drugs and always push exercise. We try to keep records of the actual weight in the chart. People don't keep accurate records. Many people will say, oh, I was 125 pounds 2 years ago, and they were actually 150. Or they say, I want to get to my high school weight and be able to fit into a size 4, and that's just not going to happen. So we push non-dieting. The turtle wins the weight loss race. Weight Watchers has held up as very good for many years. It's online. And we try to really get accurate weights. People's memory of their weight or feeling about their weight is just not always that accurate. It's more important to emphasize being in shape. After age 70, interestingly, the people who lose weight, even if it's just on a diet, tend to have higher mortality for some reason. So we don't push losing weight that much after age 70. It's really more important to be in shape. It's important to take IBS seriously. It really interferes with people's lives, quality of life. There's 3 or 4 newer meds, like Amitiza is not so new, Linzess, Trulance. Motegrity was called Zelnorm, works on serotonin receptors, 5-HT3, I believe. And they brought it back, which is a good drug. And Miralax over-the-counter. Miralax used to be a prescription. Going over-the-counter helps because there's not much evidence that our Colase and our stool softeners and even fiber really help that much. They do help some people. Vyburzi has been a very good new drug for IBS-D. Occasionally Pepto-Bismol can help because the bismuth is constipating and it doesn't really get absorbed. I think one of the biggest advances in 40 years is hospice and palliative care. People don't always call it early enough, but in the old days, people just bounced from the ER to the ICU, the nursing home to the ER to the ICU constantly, and now hospice and palliative care are so important and so helpful. It's wonderful. The only problem is sometimes we don't call it in quickly enough, and that's an issue. I do check labs fairly often. I'm most interested really in kidney functions. A lot of people take a lot of NSAIDs. NSAIDs add to maybe 75,000 deaths a year in the United States. We end up with GI bleeds and renal insufficiency. The liver, you can tolerate a lot of liver irritation a little bit. A lot of medicines will irritate the liver to a mild or moderate degree, occasionally severely, or you'll have a Stevens-Johnson, which is less common than is talked about. But really it's the kidneys that I'm interested in. And the creatinine, it's very important to look at the age and the level. And at age 25, a creatinine of 1.3 really is high, and it has to be addressed. Minimizing NSAIDs, getting a workup. At age 65, it's really not nearly as much of a problem. But at 65, say your creatinine is 1.5, mild insufficiency. If you don't do anything, you need a workup, you need to stop NSAIDs. Well, by age 70, it's increased. You have less and less glomeruli that are functioning. And then by 78 or 80, you may have dialysis, which we really, really want to avoid. So we need to protect people's kidneys. The routine labs can lead to other things. You find anemias, you find a low platelet or a high platelet. I usually draw a hemoglobin A1C after a certain age. If it's borderline, we might be able to prevent or delay the onset of diabetes. I do see a lot of hemoglobin A1Cs ignored that are 6.2, 6.6, even 6.8, and it really has to be addressed. I don't like the idea of, well, lose weight and come back in 5 months and we'll recheck it, because long-term weight loss is 8 or 10% of patients. So 90% of the time, they're not going to lose weight, and it's not going to help. Well, thank you for listening, and we're going to continue a lot more of this in part 2 and part 3, and then our other clinical pearls. It's on our site, Lawrence Robbins. Thank you.